Very good afternoon. We are going to start the last second session of the day. For the session, I want to welcome Dr. Linta Reddy ma'am. She is a senior consultant pediatric endocrinology in Rainbow Children's Hospital, Hyderabad. Welcome, ma'am. And the mic is all yours.
Good evening, everyone. So without delaying, we can go ahead and start the next session. And I'm delighted to introduce Associate Professor Ryan Paul. He's based at the University of Waikato in New Zealand. He's a clinical associate of the Maurice Wilkins Centre. He's a past president of New Zealand Society of Endocrinology and an executive member of the New Zealand Society for the Study of Diabetes. And he convenes the New Zealand National Diabetes Guidance Group. His research interests are use of technology in diabetes, management of diabetes in youth and emerging adults, education of diabetes for health professionals, and he's been awarded the New Zealand Medical Educator of the Year in 2019. So he's going to talk to us about CGM and CGM apps. And a slight change in the way this talk's going to go. If anyone wants to ask any questions, they can raise their hands in between, and he's quite happy to go ahead and answer them. So it's all.
Thank you. No, thank you, Natha, and thank you all. Please, it's a nice small group session, so if you want to ask questions, please feel very free to do so. So these are my disclosures. My first one is I'm actually an adult endocrinologist, but I do a lot of work with young adults. So in New Zealand, our young adults start from the age of 15 when they come across to adult service. And what I'll try and do in this session is cover a whole lot of common areas of troubleshooting, which will hopefully be useful in your practice. I will say it may not be 100% perfect, but it's an approach that I've found work in my own work. So we're going to start with our first case, and it's an example of alarm fatigue, which is a really common issue with CGM. We'll start off, these are all based on real cases. So it's a 14-year-old boy, type 1 diabetes on multiple daily injections of insulin. You can see his HbA1c there is 11%. A lot of that's because he's a very rational but significant fear of hypoglycemia from previous severe episodes of hypoglycemia. Now, it's unusual in New Zealand that up until this week, everyone that went on CGM, I had roughly about 20% of my patients in my clinic on CGM. They would purchase that direct from the supplier. And they would often start CGM without no knowledge of the diabetes team that they actually done so. So in this case, they use the default alarm settings, which for most sensors is 10.1 millimole per litre for the upper threshold alarm. You can imagine with his HbA1c and his current glycemia, that drew both mum and son absolutely nuts. And what they end up doing, because the alarms kept going continuously, they silenced all alarms. Then unfortunately, 1 week later, had an episode of severe hypoglycemia because his urgent low alert was turned off. So it is alarm fatigue a major cause of diabetes distress, and it may lead to turning off all alarms. Well, I've seen plenty of people just throw the sensors off after 1 to 2 days because they're sick of the alarms. And what is hard is in terms of, particularly when the models change for CGM, is actually familiarising yourself with what sensors have what alerts and whether you can customise them or not. So understand in India at present, you've only got the Freestyle Libre 1 and the Freestyle Libre Pro, and also the Dexcom G4 as being and Guardian 4 as being the main sensors used. And they're mainly just the threshold alerts. So the low threshold alert and the high threshold alert. And as you go up with the sensors, for example, the Dexcom G6 and G7 does have an urgent low alert. You can't turn that off. That we can silence it, but it will go, that stays at 3.1 millimole per litre. And you've also got an urgent low soon alert, which basically, if you're predicted to go low within the next 20 minutes, that will also alarm. Now, the G7 and the Dexcom ONE Plus also have a delayed first high alert, and I'll explain how these are useful as we go along. And what that means is you can set or delay the alarm by up to 4 hours if the glucose levels go high. And that's really useful after meals. You can imagine with a postprandial rise, you can wait until the insulin's had action and only alarm, say, 3 to 4 hours, and people can take action at that point. All sensors have loss of signal alerts and technical alerts, such as change of sensor now. And there's also others, you may be familiar with the rate of change alerts, for example, with the Guardian sensors. So what can you do to stop alarm fatigue from happening? So we'll start off. I do have quite a few people with type 2 diabetes that use CGM. I'm going to talk more about that tomorrow in the symposia. But I strongly urge people who are not on insulin or sulfonylureas to turn off the alerts, the low alert altogether. Because it's not going to have meaningful hypoglycemia. We know now that for many of us, without diabetes, our glucose levels will often go, between 3.5 to 4. We don't want that annoying our people with diabetes. And then you're customizing the upper threshold alarm. In fact, my biggest piece of advice will be this will be the alarm to get right from the get-go. And for most, particularly of my patients who have high glycemia, our median HbA1c, for example, is probably only about 9% at best. At present in the young adults, that for many I'd choose a starting upper alarm threshold of 18 or 20 millimole per litre. Some you may even suggest turning off. For those that do have the G7 or 1 Plus, that delayed first high alert, actually using that as well to minimise that distress. But the big thing is about changing the threshold alerts with time as clinically indicated. When you start off, you're not necessarily saying that glucose levels 18 to 20 millimole per litre is okay, but what you're trying to do is with time bring that down, and you may bring that down every 2 to 3 weeks until you may get down to that 10 millimole per litre upper threshold, but you're just trying to gradually get people to target without with minimising those alarms. At the same time, you may raise the low threshold alert. For example, you may have set it at 4 millimole per litre initially, but if they're still having episodes of hypoglycemia, you may choose to bring that up higher to 5 to 6. So one of my biggest things to do is when people come into the clinic is actually thinking, do I need to change the alarm settings as well as their doses of insulin? I think one thing that's also really useful is using different sounds for the different alarms. So families know what to do based on the alarm. For example, if you've got a toddler and you've got the urgent low alert going off, you can imagine you want to act right now. Whereas if it was just the high threshold alert, you may wait a few minutes, you may not rush to their aid. So it's about using different sounds for different meanings and different actions. The other thing I do is if you do have someone that's on a compatible pump in CGM, particularly if they're on automated insulin delivery, I consider turning off the CGM alarms because their pump will alarm basically for every CGM alarm anyway. So that's another way. You don't want both going off together, that you can minimise that distress. Obviously, if it's non-sensor augmented pump therapies, they may be wearing a Libre with a Medtronic pump, for example. Still keep the CGM pump on in that instance, CGM alarms on in that instance. But it's about, once again, trying to minimise the alarm fatigue. Now, the loss of signal alarms is something that's also really common. And you may have people in your practice who don't use the recommended apps. For example, they may be going with Gluco or My Sugar or other apps. It's much more common to have loss of signal with those third-party apps than it is with the recommended app, such as the Dexcom and Libre Link, for example. So that is one thing I do encourage my people to do. It's ideal if you can keep the phone or reader within 6 metres at all times, and that's without obstruction if you can, so not through 3 walls. What that means is that obviously if your child's going to school, that you have that phone goes with them. And it's not mum and dad's phone, for example. I'm sure you're all very familiar with this, but sometimes there are teething issues when you start off in terms of for many people. It is ideal if you can keep the phone with at least a minimal amount of charge and reduce the competition for Bluetooth. Because if you do have too many apps using Bluetooth, that can lead to loss of signal with the CGM alarm. I must admit, I'm no tech expert, but one thing I do talk to people about is, look, if you've still got loss of signal, try turning Bluetooth off and on. Often that works by itself. If that doesn't work, often restarting the phone will do the trick. If that's still not working, I encourage people to phone technical support. And that's usually, in most countries, that's usually pretty well done by the suppliers. I'm not saying that's true in all countries. And one thing I try and do for all my people with diabetes and the families is right from the get-go of technology, make it very clear who to phone when. And that includes when do I phone technical support or when do I phone myself or our nurses. Because otherwise, if you take all the calls, you can imagine it can become quite burdensome and take up a lot of time. So that was just on alarm fatigue. Any questions about alarms? We'll go through discussion at the end as well. But I'm going to go into another common issue is diabetes distress. You can imagine that for many of our people with diabetes doing finger pricks, that they may have little knowledge of what their glucose levels are actually doing. All of a sudden, you've got 24/7 all the glucose levels and all the information that goes with it. So here is someone I saw recently. She's a 16-year-old girl, once again on MDI with an HbA1c of 8%. And when she started CGM, it created a lot of conflict in the family, particularly between her and mum, because basically mum thought she should have a flat trace of CGM. And every time her glucose levels went high, she phoned the daughter. You can imagine the embarrassment that caused the daughter. In fact, the daughter became quite overwhelmed and ashamed with that. She was very keen to switch to a reader. So if you're not familiar, basically when you wear CGM in real time, you can choose for it to go to a reader, which is a standalone device, or to the phone. Now, the good thing about a reader is that you can't follow live. So many teenagers or people that are worried about Big Brother or people watching their glucose levels may actually choose a reader instead of their phone. And one thing that the girl was really distressed about is, why do my glucose levels go up when I'm not even eating? Mum keeps phoning me. I'm trying my best, and the distress that came along with that. So in terms of basically tips to try and reduce that, I think what's really important right from the get-go, and this is why it's great if the diabetes team can be prescribing CGM, or at least starting that conversation about CGM, is setting clear and realistic expectations for both the person with diabetes, but also all their followers. In fact, with the newer models, the number of followers can go up and up. In fact, some people may have 10 to 20 people following their glucose levels. And it's about also making sure that they're aware, not to cause distress for the person themselves. I think it's really important to know what a normal CGM trace looks like. Out of interest, in this room, how many people have worn a CGM themselves? Yep, one? Yep. So it is something which I really encourage all healthcare professionals to do. Hopefully you don't find out you've got diabetes. But I think, for example, myself, I'm lucky enough not to have diabetes. It doesn't matter what I do for breakfast. It can be a little tiny thing. It could be a big meal. I will go up into double figures. I'm only there for a few minutes before I shoot back down. I stay at 5 pretty much millimole per liter for the rest of the day. I have a bit of fun and try and challenge a whole lot of carbs throughout, for dinner. I won't go above 7. And then overnight, I'll frequently drop down sort of between 3.2 to 4 millimole per liter. And that's normal. I think CGM is actually going to redefine what normal glucose levels are. And I know that many centres already have chosen to go down for that lower limit of glucose down to 3.5 millimole per liter. But this is showing the evolution, and I'll show you what a normal CGM trace looks like. I concentrate on time out of range. Now, I know that may sound like an oxymoron or a misnomer, but we're aiming for our target time and range for most is greater than 70%. What that means is that you can put it the other way around to people and say you can actually spend 6 hours out of the day with high glucose levels. That's completely normal. You can still reach target. You don't have to be hard upon yourself if your glucose levels have gone high for a few hours each day. And just focusing at that round, psychologically, is a lot more acceptable than the other way around in terms of saying you've got to stay between 3.9 to 10. The other way also do that is, every 1% time and range, you can say that's an extra 15%. There's an extra 15 minutes each day that you've spent in target glucose levels. So even a 1% rise, you can put it, it's an extra 15 minutes. That is significant. This is something else I'm really big on. It's really emphasising the importance of lifestyle ruling diabetes and not vice versa. It's about doing everything that you normally would and then altering the management to allow people to reach their targets. And what many people do when they start CGM is all of a sudden they change all their behaviours. That may be some good stuff that's changing, but often it can get a lot of that distress because they won't exercise because they're worried about going low. Or you may get actually disordered eating and malnourishment because they're not having the intake because they're worried about the high glucose levels. And it's very much about living a normal life first and then adjusting the management around that. We've spoken about customising the alarms, particularly the upper threshold alarm. And I think it's also what the data on CGM means, and then how you use that data, how often you review that data to then make changes. And just remembering that people with diabetes probably spend at least 99.9% of their lives out of contact with their diabetes team. It's really about how can you set them up to make changes to their insulin and, in between appointments and just not relying on the diabetes team. And the good thing about time and range is that it will change each week. And many of our families have been very used to HbA1c. It takes a full 3 months to change. It can get quite depressing having to wait that long to see any positive feedback on behaviour. But actually reviewing time and range, I do say, why don't as a family you sit down for 5 to 10 minutes in the weekend, have a look at the time and range, have a look at the patterns, and then make changes based on that from what you need. Another thing I'm also very big on is making sure that every person has a treatment plan. Because they may not know what to do when their glucose levels are necessarily high, or you want to prevent stacking of insulin, for example, if they're correcting. And how can they make changes to their mealtime doses, their insulin to carbohydrate ratios, to make sure that they can get themselves down to target. And part of that is when to check blood glucose levels. Now, because you will, pretty much all the marketing around CGM is that it replaces blood glucose levels 100% of the time, which I talk to my families about. That's not true. There are certain times when you do want to check blood glucose levels. Now, the lag between blood glucose levels and interstitial glucose levels to blood glucose levels is a lot less. Now it's often only a few minutes at best, but there are times where, particularly if there's a mismatch between what the CGM shows and what the symptoms are, that it is a time to check blood glucose levels. For example, if the CGM was reading 3 and the person was asymptomatic, I wouldn't necessarily jump into treatment. That is a time that you would check blood glucose levels to make sure that they are low before treating. At the same time, if the CGM read 3 and that was symptomatic, I'll definitely be treating it. You're not waiting. The other part of that is also explaining why blood glucose levels may be different. Now, I can tell you the New Zealand experience is that we only have one funded glucometer, and that tends to read higher than venous glucose, whereas our CGM tends to read lower than venous glucose. Both are well within that 10% margin, but when you start comparing the two, there is a difference there. And it's just letting people understand that that is normal. Both are right, but you go with the one that you trust. But if you are in doubt, go with the blood glucose levels. Otherwise, the CGM is generally fine. Here is an example of a normal CGM trace on Libre. So please note you can get big spikes after meals. People will drive themselves nuts if they try and get a flat line. That is virtually impossible. It's also common to go into the 3s for people not on insulin and sulfonylureas. And I'll talk a wee bit more about that, including compression lows later on. But I think if everyone knows what a normal CGM trace is, and I do show people my trace, I find it a really powerful thing, saying, look, this is what my glucose levels do. Yours will do the same. It's completely normal. This is straight off the Diatribe website, but there are many things which affect glucose levels, far more than just food and glucose. For example, I will have, they are teenagers and not necessarily children, but I have many which will give themselves a bolus insulin for a coffee, for example, or soft drink just to counteract the effects of caffeine. Particularly around the menstrual cycle, there's lots of changes in insulin requirements, and these are it's just not food and food and insulin, and it's just trying to get that message across as well. So I'm going to come on to separate now. So were there any questions about that at all? No. Please feel free to sing out anytime if you do. This next part's going to be on diabetes team distress. So because we know that it can cause distress for the person and their family, but it can also cause distress for your team. Now, we've been very lucky that on Tuesday in New Zealand, CGM finally became funded for the first time. It has taken years of long battle, but with the funding, it's actually come along with a whole lot of stress for diabetes teams about what do we do with these reports. And I really encourage you to keep fighting in all your countries. I know that most countries at this meeting do not have funded CGM. And it's about continuing that battle. We've only got it for type 1 diabetes, but it's a start, as it has been in every country. And a big part of my last month I had a lot of colleagues, both in secondary care within the clinic and in primary care, just completely overwhelmed by CGM reports. Common thoughts were, I do not have time to look at the 15 and 20 page reports. I don't know what I'm looking at. This is so much information. What are the best things to look at? What can I skip? I understood HbA1c, but I don't understand CGM. And how can we make that easy for our people? This is a way I teach. I'm not saying it's a perfect way, but I basically explain to everyone, I think you can easily interpret CGM within 1 to 2 minutes. You often don't need to go any further past the first 2 pages of the report. I'm going to show you now how to do that. It's just providing the education and confidence to do so. So there's only 5 steps. The first step is there enough data to make management decisions? Now, this is really relevant for those on intermittently scanned CGM, which I know you do have the Freestyle Libre 1 as a mainstay here in India, for example. International consensus is basically if you've got more than 70% of sensor usage, that's deemed adequate. Now, sometimes I think you can make clear decisions on less data, but that really relies on data at the same time every day. Maybe they only scan once a day, and you can use that 8 hours worth of data to make changes at that time. I have had plenty of teenagers that wore the Freestyle Libre 1 for their parents and never scanned, and that's the hard part as well. You're trying to at least get that using the data you've got to make decisions. The next bit is knowing what other targets that we're looking for on CGM are our people reaching it. Now, for most people, we're aiming for at least 70% time and range. So that's glucose levels between 3.9 to 10 millimole per litre, or between 70 to 180 milligram per decilitre if you use those units. Now, that is obviously customisable, but that is the mainstay. Time and tight target range is becoming increasingly more commonly used. So that's aiming for at least half glucose levels between 3.9 to 7.8 millimole per litre. That's also, it's great in adults. It's the same target range we use in pregnancy, but we're aiming for greater than 70% in pregnancy. Now, one thing our colleagues and our families are very used to is the glucose management indicator. So that's a calculated HbA1c off the CGM. And so for most, that may be less than 53 or 48 millimole per mole, or less than 6.5 to 7%. Now, if you take 60 days, or at least 60 days of CGM data, that marries very well to a laboratory HbA1c. In fact, for my people on CGM who are using it reliably, I don't measure HbA1c anymore. Most of the time, in fact, this is particularly more true for older adults, you find all the limitations of HbA1c that you had. I mean, HbA1c is only as good as hemoglobin. And if you've got altered hemoglobin turnover for whatever reason, you will have a falsely low or high HbA1c. And that's often when the GMI is a very useful marker in that situation. But it is something which families are very used to, and it may be to start off with, they actually look at the GMI, because that will also change from week to week as well. And the third step, ask yourself, is there any time below range? Or is there any hypoglycemia? And it's thought up to 4% of time in mild hypoglycemia is satisfactory, but obviously you're aiming for no glucose levels less than 3 and definitely no symptomatic episodes of significant hypoglycemia. And that's the first 3 steps. I thought I'd show you what it looks like on some common platforms. The good news is for almost all the sensors, they all look very similar. There's some minor nuances from brand to brand, but they're all the same. But here's Libre View. The first one that you're looking for is what's my sensor usage. Remember, that's the first step. Here is someone that's on the Libre 1. They're not doing too bad at the time, but remember we are aiming for greater than 70% if we can, but they're at 65%. Your second step is, are they reaching targets? And you can see that they've only got 22% time and range, and the equivalent GMI of 9.4% or 79 millimole per mole. And your third one is, do they have any time below range or hypoglycemia? And it's 0. So all of a sudden, you don't have to go any further. You know this person needs escalation of therapy, and you can do so, without necessarily any risk of making any hypoglycemia worse. You're obviously going to go through that, but you know from this, you don't have to go necessarily any further before knowing what you have to do when you look at the subsequent pages. Here's what it looks like on Clarity. You can see sensor usage up there on the right, it's 100%. That is one benefit of real time, as you're probably all very familiar with. You do often get very good sensor usage. So that they're doing well from that point of view. They're also doing very well in terms of reaching their targets. 76% time and range, an HbA1c of 6.8%, and only mild time in mild or very small amount of time mild hypoglycemia. Saying that, you may still choose to de-escalate therapy in this person if you're worried about hypos, but it lets you know to the subsequent pages, what am I thinking, what do I need to do as next steps of management. So we're going to go now to our fourth step, and this is looking at the ambulatory glucose profile, which shows the daily pattern of glucose levels. This is on the second page of the report. I've just shown you the first page. This is the second page, and I often think this contains all the information that you need. Often you don't, probably say at least 95% of the time, for example, I don't go past the second page of the report for CGM, and that's how you can make it quick. And I'll show you why in a second. But then you've looked at the ambulatory glucose profile, and then you're adjusting management as required. As a basic rule of thumb, I say fix hypoglycemia first, and then you fix hyperglycemia. And then you can check the daily glucose patterns to say, are the changes I made going to be safe and effective? And that's the process. Basically, it is a process I go through for every person. So for those who aren't familiar with an AGP, this is what it looks like. You've basically got the daily pattern for that time period, starting at midnight, going through across the day to midnight. The dark line has the median glucose levels. The darker shading is between the 25th to 75th percentile, and then the lighter shading between the 95th to the 5th percentile. So you can see there, all of a sudden you've got the glucose levels all across there the whole day. And the good thing is on the AGP, you'll also get a mini version of the daily profiles below it. And this is where you can see what's going on from day to day. And you can see what is working, what isn't working. This will be true probably for most of my people in my practice. Most will probably be on too much basal insulin and not enough prandial or mealtime insulin, and there's multiple reasons for that. But you can see you've identified that overnight is the potential period of hypoglycemia. You can see that's happened on Sunday and Wednesday in particular, which may thinking about as the extra activity and what was the story then. So for this person, for example, I'll be very tempted to reduce their nighttime basal insulin and then increase their mealtime insulin across the day. But that's just showing how you can make those changes just on the first 2 pages without going any further. And I think it can be a really useful approach for those that do get overwhelmed. So is there any questions about that at all? No, very quiet, very well behaved. Right, our next case is around adherence issues. It's all very well and good getting the sensor and wearing the sensor, but it needs to stay in. And this can be a common issue. So this is someone I actually saw the week before I came here. It was a 15-year-old girl with a G7 and with a tandem pump and control IQ, so using automated insulin delivery. The major issue is that her sensors are only lasting 1 to 2 days at best. So she had only 30% sensor usage, and even when the sensors were in, she was often out of connectivity. So her time and automation was only about 25% at best. As a result, her HbA1c was around that 9%. And I think it's really important when we think about, basically, ideally, we'd have almost everybody that wants automated insulin delivery on automated insulin delivery. We don't need to be worried. For those on non-sensor augmented pump therapy, we do worry about their safety, in terms of monitoring glucose levels, carb counting, etc. We don't necessarily need to worry about that with automated insulin delivery. But the biggest safeguard with that is actually wearing the CGM. If they're not wearing the CGM and then there's no monitoring of glucose levels, there's probably no monitoring of ketone levels, that is a time when you do get a little bit more nervous. So keeping sensors in is really, really important. And particularly if people are self-funding, they're a lot of money. If it falls out, they probably only have the money to restart again in a week's time, not immediately. I will say that in a lot of countries, the suppliers are really good at replacing sensors that fall out, but I know that is not true in every country. But it is something that's worth trying to start off with. Now, for her, she tried multiple adhesive products, both underneath and over top, with limited success. And she was actually really keen to return to the G6 because for her, it was bigger, it actually adhered better, and she had better connectivity and greater time and automation. And I was just thinking about how would you approach this in your practice as well, because this is a really common clinical scenario. So we're going to go through some tips on that. These are all very common sense, but sometimes it's good to point out common sense. The first one is choosing sites that aren't going to get knocked. Now, just being aware the Libre is only approved for the outer arm and not any other site on the body. Saying that, we've done some small studies in New Zealand. We've tried the Libre on other sites such as the chest, the leg, the abdomen. It actually seems to work very well, but they're very small ends, like 20 patients on each site. I wouldn't be recommending it, but what I would say is I do have many patients that wear the Libre not on the arm, but I do say please make sure you check your blood glucose levels for each sensor to make sure that it correlates well. If so, then it's probably safe to go off that. But you are practicing off-label when you do use other sites on the arm. And if you're lucky enough to have a choice of sensors in your country, that may be one reason to say, look, I'm going to choose Dexcom instead of the Libre because I can use it on the abdomen and the buttocks. You do go back to basics in terms of around that insertion technique, particularly dry skin. Some people do not wait for the alcohol wipe, etc., or the nasal spray, and I'll talk a bit more about that, to dry, and so the sensor doesn't stick as well. One thing I think is really useful about wearing a sensor is know how to care for it, because if you do wear tight clothing, and particularly when you dry yourself after swimming and shower, it can be a bit of an art wearing a sensor to make sure that it stays in. So it is making sure you take care with that. I do recommend checking the sensor every day, even if it's just for 3 seconds. Make sure that is all the adhesive, is it still stuck down? If anything's coming up, can you stick it down? Do you put on an adhesive at that stage? Many of my people, I get them to go to the supermarket to buy an 80 to 100 rupee bandage and put that over top, and that will often do the job for the rest of the sensor life. It doesn't necessarily have to be expensive adhesives to keep the sensor going. Use whatever works is a good take-home message. There are products, though, that you can use to make the skin more tacky or sticky, and this will vary from country to country as well, what you have available. I do find them useful in some situations. Often the supplier of the sensors may have a stock as well, and you may find that as a useful adjunct to keeping the sensors in. But it's about, often you need to try every step for those really difficult ones. But changing the site's probably one of the biggest ones. And toddlers can be a big challenge here, in terms of stopping them to rip out the sensor. And it may be, for example, that you do put that on the leg and bandage it up, on the back where they can't reach it. Usually sleeping on it's absolutely fine if you're worried about that, but that's some of the things we can talk about in discussion. Go for it.
Somebody wants to go to the gym or do weightlifting.
Yep.
What is the best area to use a sensor?
Yeah, I think whichever works for them. Lots of people do different types of exercises at the gym. I've found that still often on the arm works very well. I do say the back of the arm though, because that's the site less likely to be knocked. We're lucky in New Zealand that heat isn't an issue. To be honest, we probably don't go above 30 degrees 99% of the time. So sweat isn't that much of an issue, whereas I imagine in India, particularly in summer, that it is. And you may choose a site that doesn't sweat as much, particularly for those that do exercise and gym work, and that may be something that influences your decision around that. But that will be, I talk to people about trying different sites as well. But for those, I've found the arm still works very well.
So apart from the arm, what are the other sites that you would advise?
Mainly the arm and abdomen are the main ones. But I'll be honest, I don't deal with young children. So I imagine young children like the upper outer buttocks might be useful as well. Or you may choose other sites. I do have some people that choose the legs. The other thing, which is probably also more apparent in India than at home, is that people get more worried about their appearance. Because it's showing, and that may be something which influences people, to change the site, and it may be that they choose to wear it on the chest, for example, where it's under clothing. But if it was the Libre, that is one time I would be saying, please do check your blood glucose levels. And I say do that with every sensor.
Thank you.
Yeah, that's okay. Yeah, so yep.
What is your say on use of abdomen as a site of CGM?
I mean, Libre, I'm asking.
Oh, for the abdomen for...
Abdomen.
Yeah, I find many of my people, particularly with Dexcom and Guardian, use the abdomen. That's their main site for using CGM. It works well. One thing I've always worried about with particularly the little kids is they don't have much skin real estate, so to speak. And they might be wearing a pump and CGM and keep moving it around. But the abdomen it works very well.
And sir, does the skin hairs, not a very hairy child, but I mean the presence of hairs on the arm, is it going to cause the adhesion to come out? Or
yeah, it can do. It can also irritate the skin too, which I'm actually going to come to in this part. Which I might go on and talk about that.
I'm not asking about skin reactions because of the hair in the skin.
Yep.
I mean, is it
Yes,
can it
yep.
cause to come out the not adhesing well?
Yeah, no, I do talk about people about shaving, because that will, I think that is important in terms, again, that sensor to stick well, and also reduce the chance of skin reactions, which aren't uncommon, and it also hurts a lot less when you rip it off. Which little kids do worry about.
Sir, and I have one more question.
Yeah, sure, go for it.
Sir, the glycemic variability in the case 3 that you have mentioned, how do you actually suggest? I mean, what do you suggest? Because the 25th to 75th percentile of the variation seems to be more, that too in the middle of the night.
Yep.
So would you suggest it could be the one thing is that the meal and what is generally thought is that the meal and insulin mismatch is usually there, but middle of the night, what will be nocturnal, there is so much variability is there, no?
Yeah, it is. So I mean, a lot of that nocturnal variability comes from the evening before, but it is something. It's right. So I didn't actually put glycemic variability up here at all in terms of a metric. It is very well linked, and coming more and more data on the link between glycemic variability itself and complications of diabetes. So it is something we look at. Personally, I don't make any changes based on the glycemic variability alone, but I do look at the profiles and say, look, this is what we need to change to reduce that variability and smooth out your glycemia. So it is something to look at, but it's an important variability, and that's where both the ambulatory glucose profile and the daily glucose profiles below becomes useful to look at both, because it may be that it's only 2 days a week that's causing that significant variability in that profile across the whole week, if that makes sense. And what's different on those 2 days, for example, that we need to change. And that may be, maybe that's the weekend when they're not doing any exercise or anything like that, and that's the time they need more insulin. It's about trying to see where in your life is that variability so we can make those changes. Does that make sense? Yep. Okay, so any other questions before we move on to skin reaction? Yeah.
So does compression over the CGMs have some impact on the glucose variability?
I'll come to that. I'll talk about compression loads. That is a good point. It is a big fear, but to be honest, most of the time with the adhesives, a bandage is absolutely fine. You're not going to necessarily get any variability, but if you do get too much compression, and generally that's from positioning and lying or pressing up against something, you can get compression loads, but I'll talk about that in a few slides' time. Well, we might move on to skin reactions. Here's a case, a 14-year-old Māori boy. So Māori are the indigenous people of New Zealand. He is struggling, HbA1c of 12%. Unfortunately, it's not a too uncommon story. So he started the Freestyle Libre 1 on the outer arm, and almost immediately started developing pain and itchiness underneath the centre. He hated it. He wanted it off immediately. Now, this isn't the exact photo, but it was actually worse than this, but just showing you an example of a common type of reaction that you can get under a CGM sensor. So in terms of around skin reactions, so thankfully severe skin reactions are rare, but mild to moderate reactions are still really common. In fact, they're reported up to 30%. And it's often due to irritant or allergic contact dermatitis, either from the sensor itself or potentially from the adhesive over top of the sensor. In fact, the pattern you get on the skin is often really useful for determining is it the sensor or is it the adhesive or potentially both. But it can cause pain, it can cause distress. In fact, people may choose not to wear CGM as a result, which is obviously what you do not want, and it is almost always preventable. And I think that's the important part, and I'll talk about that. One thing that is also really useful to know, and one reason why I hope that newer models of CGM keeps coming out in India and all other countries, is that the rate of skin reactions is actually a lot lower. So it's the acrylates and the sensors which seem to be causing most of the issues around the dermatitis. Now, for example, Freestyle Libre dropped isobornyl acrylate, which is the major irritant after the Libre 1. So Libre 2, 3, and 3 Plus have far, far less skin reactions as a result. So if you can minimise the acrylate content, that will go well. But in terms of preventing, and often this is common sense too, but you're rotating the insertion sites and you're trying to choose sites which have no skin irritation already. If you do put a sensor on top of skin that's already irritable, that does greatly increase your chance of a site reaction. So you may need to shave, as we spoke about. The other thing is often you will switch, if you're wearing the Libre, for example, you will switch arms. So you might, left arm one sensor, right arm the next sensor, back and forth, not always the same site. I do recommend not putting on any lotions or oils within the preceding 12 hours. Absolutely fine everywhere else in the body, but just at that sensor site, I would be avoiding it, just because you're more likely to cause irritation. Washing hands and cleaning the area still remains important. If you're still getting issues despite that, often a barrier cream can be really effective. And then once again, the number of brands available depending on which country that you're in. The barrier creams often also do make the skin a bit more tacky and sticky and help with adherence themselves. So I use quite a lot of barrier cream. The other thing which I find really useful is fluticasone nasal spray. So the nasal spray used for hay fever, just at a very low dose, 1 to 2 puffs on the insertion site, let that dry for a minute, and then put the sensor in. And to be honest, that probably stops at least 98% of skin reactions from happening. So you still have the 2%ers, and they're the ones that think about switching CGMs, because they may not get the same reaction with a different CGM, trialing different adhesives. You may need to think about referring to dermatology colleagues for skin or patch testing to work out what the exact irritant is. But I will have roughly probably at least 500 people on CGM now, and I will have, I do have 2, this is out of the whole lot, who wear a non-allergent tape that they then put the sensor through the tape, and that prevents the skin reactions, but everyone else has been able to wear it without. And we have quite an atopic population in New Zealand. We've got a lot of hay fever, even asthma and dermatitis. So just to let you know, this may not be an issue in your practice, but there are tricks of the trade to avoid any skin reactions from happening. Just a couple of other areas. So we're talking about the compression lows. So this is a big fear, and I've seen basic compression lows not being recognised, and then inappropriate changes in management taken, and also vice versa as well. Now, the biggest time that you worry about compression lows is if you see a rapid drop on CGM, the person's not symptomatic, and then you have the change position, and you get that rapid increase back up to baseline. That is very stereotypical, classical of a compression low. If you get that slow drop overnight in glucose levels, that's not a compression low, that's probably real, and I would be reducing the insulin in that situation, but I would not be worried about changing insulin at all with a compression low. And so it is, you may think about changing the sensor site in that situation. Many people, for example, will lie on the same arm every night for sleeping. So that may come into it, but it's just being aware. Please look for that sudden drop off for it to be a real compression low, because otherwise it may be real. This is a first world problem, but it is something, as more and more people use CGM, just to be aware of, because when the new models of phones and smartwatches come out, just by default, the paired apps with CGM will always lag behind those models. For example, people got excited about CGM being funded in New Zealand, so they went and bought out the latest iPhone 16, only to realise that it wasn't compatible with the CGM that we've got. So all of a sudden you've got, a new flash phone. It may not be the best. The other thing to be aware of is you also have people, if they have automatic updates on the phone, on the operating system, that may also lead to loss of compatibility. So you may actually think about, just having one phone that stays in old operating system just for using with CGM, and that's the way that does. And in fact, the different compatibility may actually be a strong influencer on which CGM they choose. So our 2 main CGMs that we've got funded in New Zealand now, the Freestyle Libre 2 and the Dexcom ONE Plus. Now, the Dexcom ONE Plus will only go to Apple Watches. It won't go to any other watches. It will only go for a very narrow range of Android and iOS or Apple compatibility, whereas the Freestyle Libre actually gives a whole lot more options. It will go to Fitbits and Samsung Galaxy watches, for example, and Android 8 to 14 systems. So it is about checking the compatibility, and that's usually the suppliers are very good at that and pointing it in the right direction. But I think it's also really good that, even though we may not be technology experts, that diabetes teams are aware, or at least can point people in the right direction where to go to check that. And also when people, just knowing that, when people, for example, have Dexcom, where actually the G6, the G7, the ONE Plus, Clarity and Follow are all different apps. It's just not just one app fits all. It's also about knowing which app goes with which sensor as well. So in terms of switching between CGM systems, I think this is going to become increasingly popular, and often that's for very good reasons. What is great is that there's now more and more interoperability between CGM and pumps. And what I mean by that is, we used to only have, it was one sensor with one pump, and that was your system. But now, for example, our two funded pumps in New Zealand are the IPSO and Tandem, and they will both work with the Freestyle Libre 3 Plus and our Dexcom G6, G7. So it doesn't matter what sensor you're wearing, it'll work with both pumps. So we're getting closer to our dream of that people are able to choose their sensor that's best for them, their pump that works best for them, and their algorithm that works best for them for their automated insulin delivery. So we are getting there. What has been really good in New Zealand, other countries, we've had some competition for the traditional CGM. So we have people like Adix and Lynx come in and offer CGM a lot cheaper prices, which then drove down the prices of Libre and Dexcom, and hopefully that happens more. There's many free trials of CGM that you can get. It's increasing funding for that. And there's more and more data saying that ideally CGM should be started in hospital if you have access to it. When they come in for their diagnosed with diabetes, we're starting it straight away. They know what CGM is, they know what normal is, and how to go from there. This is lucky enough if you do have the choice. I think it's great that people with diabetes choose a sensor that works best for them. And there are little nuances between the sensors. I've spoken about getting closer to our dream. And I'll just last point is I think in an ideal world is us as diabetes teams being that main source of information for people with diabetes and their families. I don't know what it's like in your country, but it was really problematic in New Zealand when people got their CGM sensors from the supplier and not from their diabetes team. For example, in continental Europe, you still need to get prescribed your CGM by your diabetes team. That's how you get your CGM. You can't buy it over the internet that way. So because putting in CGM is CGM is much more than a sensor. It's everything. It's all that information that goes with it to maximize that benefit and minimize the distress. But I hope you found that very useful. I hope it wasn't teaching you to suck eggs too much, because I know many of you are very familiar with CGM, but happy to take any other questions if you have any.
Any questions?
Some parents say that the young children, they refuse to put the CGMs. So what do you say to that?
Yeah, that's a good question. So I always talk to people. It all depends on what the reasoning is for that. One big one's pain, but I always say that I think inserting a sensor hurts about 10 times less than a finger prick, and most people can relate to the pain of a finger prick. And just knowing that is often enough, perhaps, to get over that first barrier. It may be that they don't want their friends to necessarily know that they've got diabetes, or other people, because it's visible on the outer arm. That's maybe when you choose a site that's not visible. Another part of it may be that they don't, phones are banned in schools, so they don't necessarily have a phone in school and cause that. We had a big campaign last month in New Zealand, for example, about making sure that all schools were aware that basically kids with diabetes need phones on them, and trying to get over that barrier and reduce that. So we had a whole lot of information go out to schools, so teachers weren't being necessarily nasty or reacting to the kids wearing sensors and getting over that barrier. And then it's just trying to see if that hasn't worked, seeing what other issues there necessarily are in terms of helping with the sensors, and just trying to find a solution that works. Other part of it, I talk about technology as well. It's also okay to have a holiday off technology. It may be that 80% of the time you do wear a sensor and a pump, but you may choose, you may be going on a beach holiday, or you may be, going away somewhere where you choose not to wear a sensor. Often that's the time where a sensor would be great, but it's also about just being realistic and what works for people as well. I will say that everyone's different, and just trying to work out what works best in that situation for your family.
You might have answered this, but maybe I wasn't paying attention, sorry.
That's right.
Are there any other sites that we can put the sensor beside the back of the arm
Yeah.
That's what do you suggest for the younger kids who doesn't like it on the arms?
Yep. So if it is the Libre, I do say that it's absolutely fine. I've people wear CGM everywhere on the body. It seems to work well. I do say check blood glucose levels if you're not wearing it for the Libre, not wearing it on the arm, just to make sure that it does correlate well with what the CGM is showing. If it's the Dexcom, for example, they're also approved for the abdomen and the buttocks. But saying that, some people may choose to wear it on the legs. And in that situation, I do say make sure you check blood glucose levels if you're wearing it on the legs too. So, but not wearing on the arm, maybe say, look, actually, we're not going to use the Libre for you. We use the Dexcom, so you can wear it on the abdomen, so no one can see it. It will work well then. So, yeah, there are small studies basically showing that it's fine anywhere. I do get worried though if there is edema under the skin or anything else which may make the reading unreliable. That's much more of an issue in older adults than it is in children. It's just thinking about as long as there's some skin and normal interstitial tissue there, it should be fine.
I have a problem whether you can solve it for me.
Yep.
So it's a young child with mild autism who doesn't like the thing sticking on hips. Any other way you think we could help? Do you have any adult patients with autism who?
Oh no, I was going to say, my young adults with autism generally do very well with diabetes. They're so structured in their routine that they actually find CGM really useful and build that into their routine really well. Often getting it in the first time, I will say, is the hardest part. Most people have found that once they've had their first 2 sensors in, they're absolutely fine. It's just getting over that first step. If it really is the pain of insertion, it's a big one. Then do think about distraction or ice or other things to help around insertion. But there will still be some people that won't wear it. And in the younger kids, it can be easy that you put it in and just really wrap it up so they can't take it out. And that can be, one strategy of getting around it, and they realise it's not so bad. But you probably will still have, a few patients that won't wear it no matter what you try. I've got no magic wand for them, unfortunately. But I'd just suggest just keep on trying. They are useful. That's when I use my clinical psychologist a lot to try and actually get down to what the actual issue is and to help build strategies around that. As we often don't necessarily have the time in our clinic appointments to do so, but the psychologist, if you're lucky enough to have one, may have that time to work with the family. That's fine. Yep.
CGM placement on abdomen in an obese person, does it work well?
Yeah, it seems to work absolutely fine. I anecdotally haven't found any issues at all.
No dislodgement.
No, I guess if you have really morbid obesity, it may be an issue, but in most people, it's been absolutely fine with no issues whatsoever. I guess if they sweat a lot, that may become an issue there, and you may choose the arm then. But it's about basically CGM seems to work well in most places where you put it. It's just about finding a site that works best for your person with diabetes.
So are you putting CGM to every age group?
Yes, so now we have funding, because the biggest issue before was people couldn't afford it, and it was a real difference between those that had money and those that didn't have money. So now that it's funded, we're trying to put on everyone.
Neonatal diabetes as well.
Oh, so we're only funded for type 1 diabetes, and pancreatic diabetes. We're funded for that too. But basically, in that group, we're trying to get everyone to use CGM. We've still got no funding for type 2 diabetes. There are some groups that will still clearly benefit with type 2 diabetes. I'll talk more about that tomorrow. But I think ideally that everyone would have CGM. That would be the dream. Anyone that wants it would have CGM. And it's such a powerful tool that we can use improving glycemia.
Any experience of using CGM in hyperinsulinism, congenital hyperinsulinism children?
Short answer would be no. Not congenital hyperinsulinemia. I use it a lot in people with type 2 diabetes. I've got a few with insulin resistance, but not necessarily like monogenic insulin resistance, but not necessarily congenital, not from birth. Yep.
The adhesive the adhesive of the CGM, and on the top of it, if we apply a bandage, there is some, color change or like the darkening that happens when we remove it.
Right.
And that doesn't go away for a long time, like 6 months or so. It still remains that circle, that darkening kind of,
Yeah.
maybe dirt or whatever, but it doesn't leave also.
Yeah, I must admit, I haven't had that issue myself. It is one thing if you thought it was a skin reaction.
No, it's not a skin reaction, sir.
Do you think it is?
Most of us must have faced.
like a circular mark.
It's a circle mark, probably a dirt or like whatever, but it doesn't go also even after like washing with antiseptics.
Doesn't go.
Yeah.
Probably most likely the sticky tape because it's just like around just the exact shape
Exact
of your
shape.
sensor.
Have you faced any?
Area. Yeah, so I've got no easy answer for that. Unfortunately, I don't know whether we have like different sensors, and that's why we don't have that issue.
Or probably it's our skin
It might well be the skin, yeah.
reacts to it.
I don't know whether trying those strategies to reduce skin reactions makes any change at all to the skin colour. I think if people are getting really distressed about this change in skin colour, you could try some of those things I spoke about to see whether that makes a difference. If it didn't make a difference, I wouldn't bother continuing with it. But yeah, just give it a go.
Thank you.
Yep.
Thanks for the talk.
That's right.
Actually, I would like to ask if there's a presence of public funding among the young diabetes type 1 in children. Would you foresee there's a reduction of blood glucose checking because maybe some parents would be using that reading to come to a decision for treatment? Would you foresee?
Yeah, it makes. I can't underestimate how powerful CGM can be in terms of improving management. Up until now, this is an example. Up until now in New Zealand, we had separate government funding for children with diabetes. So we had about 99% of our children with type 1 diabetes were using CGM, but there was no funding for adults. So unfortunately, as soon as they turned 16, our use of CGM went from about 98% down to about 20%. And I know it's not the best time of life because that's often the hardest time in terms of glycemia, but there's just a massive increase in glucose levels as a result. If you look at the studies which show that they've put, doesn't matter which age group you use actually, but including children, if you start children on CGM, you see the reduction in glucose levels. If you take CGM away, you see the glucose levels go back up. It's just, yeah, it is. I'll be campaigning for funding for everyone. We had, I'll show some data tomorrow which helped convince our funding body to actually fund CGM in New Zealand because we've literally been fighting for at least the last 10 years to do so. And a lot was because we showed that all of those people who had high glucose, a lot was based on socioeconomic deprivation and on ethnicity. And if we gave them CGM, it took away all inequities. Basically, it brought all those top groups down to where everyone that could afford CGM was. And that's why I wish everyone could have access to CGM. Because it doesn't matter, what ethnicity, what income, you can still get people doing a lot better than what they're doing at the moment.
Thank you very, very much it was an excellent talk and I think we had quite a good discussion. Thank you very much, Professor.
Thank you.
Thank you, sir. Thank you, ma'am, for chairing the session. May I request Dr. Divya Lakshmi to please felicitate the chairperson? Thank you. Sir, please come for the photo. Group photo. Yeah. Ma'am, group photo. Yeah, he just...
glad you enjoyed it.
Nice. Thank you.
Yeah,
That's very good.
Let's take a few more.